Good morning, everyone, and welcome to TIRO by MD's webinar series. I'm your host, Camilo Gonzalez Velasquez, and I couldn't be more honored to moderate today's discussion with two world-class leaders and true innovators in thyroid nodule and thyroid cancer management. Today, we're diving into a topic that is rapidly changing the landscape of thyroid cancer management, and we'll dive into the 2024 International Expert Consensus on ultrasound-guided thermal ablation for T1N0M0 Papillary Thyroid Carcinoma. First, I'm delighted to introduce Dr. Jonathon Russell. Dr. Russell is the founder of the Russell Center for Endocrinology, past president of the North American Society for Interventional Thyroidology. He used to be associate professor and director of endoscopic and robotic thyroid and parathyroid surgery at Hopkins in the Department of Otolaryngology and Head and Neck Surgery. He also directed a multidisciplinary thyroid tumor center where he advances innovative techniques and methodologies for thyroid care. Dr. Russell led the largest North American series of scarless vestibular surgeries and was part of the team of head and neck surgeons that offered radiofrequency ablation for thyroid nodules at first. Nationally, he serves as chair and the technology committee and endocrine section of the American Head and Neck Societies, and his current research focuses on outcomes and safety of these very novel approaches. Thank you, Dr. Russell, for joining us. Next, it is my privilege to introduce our expert discussant for this morning, Dr. Catherine Sinclair. Dr. Sinclair is a board-certified otolaryngology head and neck surgery, both in Australasia and the United States. She completed fellowships in head and neck surgery and laryngology at the University of Alabama at Birmingham and the New York Center for Voice and Swallowing, respectively. Dr. Sinclair is a leader in the field, serving at national committees, including the Executive Committee of Endocrine Section of the American Head and Neck Society and the Guidelines and Statement Committee of the American Thyroid Association. She has published extensively in thyroid disease, thyroid cancer, and surgical techniques. And besides being a pioneer and thought leader on the use of thermal ablation techniques globally, with her team, she recently pioneered a new continuous vagus nerve monitoring technique that can monitor sensory and brainstem pathways during thyroid surgeries. Dr. Sinclair, thank you for being here with us today. Before we begin, I'd like to invite all of our audience to send in any questions that they might have through the Q&A function. And I'm going to now give the presentation over to Dr. Russell for his presentation.
Thank you, Dr. Gonzalez Velasquez. It's a pleasure to be with all of you and really an honor. I was asked to review a paper that I was an author on regarding the 2024 International Expert Consensus on Ultrasound-Guided Thermal Ablation for small thyroid cancers. And so that's what we're going to talk about today. Oh, wow. There we go. Good. I don't have any disclosures, but I am the past president of the North American Society for Interventional Thyroidology, as you heard earlier. And anybody who's listening to this hopefully has some interest in percutaneous or less invasive therapies for thyroid cancer and thyroid tumors. And I very much invite all of you to join us in this society. It's a fantastic society that is really moving the needle forward. So at NASIT.org, our next meeting is in Portland, Oregon, and we would love to have you all there. Also, at the Russell Center, my last plug is I am looking for people. So Dr. Shaha, I already invited him to be my partner, but we are looking for more than just Dr. Shaha. So this paper was published in 2024, and as you can see, it's got a pretty extensive list of pretty well-known authors. And so we're going to go through those authors just a little bit. But I'm going to have to move this down to the bottom so you can see what I'm trying to say. But the too long didn't read for this paper is just the idea that thermal ablation should be first line for T1A tumors, and that it should be an alternative that you discuss for T1B tumor, papillary thyroid cancer tumors. And just to give us a little bit of the background and set that, we all know this information already, but T1 tumors are any well-differentiated thyroid cancer that is smaller than 2 centimeters, with T1A being tumors that are smaller than 1 centimeter, and T1B being papillary thyroid cancers that are between 1 and 2 centimeters. So that's what we're going to be talking about today as we go through this. So for today, we're going to go over the background of where we are in the world right now with papillary thyroid cancer. Then we're going to go through and discuss this specific paper, and then we're going to talk about the recommendations that come out of this paper. This is the background we're going to go through very quickly because anybody in this meeting understands all of this. Thyroid nodules are ubiquitous, up to 80% if you look hard enough with an ultrasound. And we know that thyroid cancer, papillary thyroid cancer, is very indolent. This is an older graph, and you can't even see the bottom part of it because of how I'm sharing my screen, but you can see that mortality line down at the bottom shows that mortality has been flat, even though the incidence of thyroid cancer is increasing. Now, we do know, this is a paper from Dr. Sosa looking at the incidence of papillary thyroid cancer seems to have stabilized, which is good news, probably because of some of the modifications that are happening as far as how invasive we are being with our imaging techniques and our biopsies. But we also know that these papillary thyroid cancers are associated with obesity. And so will that trend also start to level off even more as we start to use some of these anti-obesity medications? Who knows? But we know that thyroid cancer is everywhere and it's very indolent, doesn't usually kill people. And we also know that lobectomy, I always feel like I have to say this whenever I'm speaking to any audience, if you're treating small thyroid cancer, lobectomy should be the standard of care. We don't need to be doing total thyroidectomy for small thyroid cancers unless there's some sort of extenuating circumstance. That would be rare for us, why that would be what we would do. And as you can see here, the reason that we do less surgery is because doing less surgery has fewer complications, whether you're a low volume surgeon or a high volume surgeon, which just makes intuitive sense. So why should we not just do a thyroid lobectomy for everybody? It's good surgery. I love doing this surgery. We all love doing this surgery. It's fantastic. Our patients we know do in general very well. So what's wrong with just doing thyroid lobectomy for every single person with a small thyroid cancer? Well, we know that some percentage of patients, somewhere between 20 to 50% of patients, are going to end up on lifelong thyroid hormone replacement, or at least supplementation, for the rest of their life. We also know that there's a very low risk to the voice. In experienced hands, that risk is probably less than 1%, but we know it can be as high as 5%. And we know that temporary palsy rates are even higher than that. We also know that doing surgery is expensive, and then you have the surveillance element that comes into it afterwards. And we know that sometimes patients have to have a visible scar if they have thyroid surgery. And we know that for some patients, having a scar is a big deal. And I'm not going to talk about that. I actually don't think that patients with small thyroid cancers should ever have a scar, but that's a different lecture. And I'm happy to come back and give that one sometime. But for right now, these are just the reasons that some patients might not want to do a lobectomy. Now, could we do more than doing less surgery? Meaning, could we do more than just doing a thyroid lobectomy? Well, yes, we can. This is also data that you are all familiar with. A long follow-up patient population, pretty significant, more than 1,000 patients in Japan who had small thyroid cancers. They watched those cancers and they saw that very few of them grew and very few of them had metastases. And so the risk of doing nothing was, meaning active surveillance, not actually doing nothing, but the risk of not having surgery right away was actually lower than the risk of having surgery right away. And for that reason, we have this idea of active surveillance coming into play. But that's not just an idea for active surveillance. That's an idea of this data gives us the potential to grow into all sorts of new techniques that we can use to treat thyroid cancer. These small thyroid cancers do really well. And so what can we do to be the best? Because we know that if we don't do anything, patients probably won't die from this, and we're able to salvage them with very good efficacy, at least as good as if we did surgery right up front. So what else could we do? Well, we know that we can tell these patients not to have surgery at all, and that's the active surveillance that we talked about. But what are the problems with that? And why should we be looking for something even better than active surveillance? We know that some percentage of the patients will have growth. Some percentage of the patients will have metastases. Some of the patients will disappear to follow up. And all of that creates this world in which patients who have small thyroid cancers feel very anxious. And that anxiety encourages people to have surgery when they might not need surgery. And in addition, we know that active surveillance has cost associated with it. And if you've got a patient in her mid-20s and you're telling her that she needs to have active surveillance for the next 75 years, maybe a simple surgery would be better than that, because you could then tell the person that they were cured after 5 years and they could go on about their life without having to think about it in the back of their head quite as much. And so all of these things add up to make us wonder, is active surveillance better? We're used to the Goldilocks analogy where it's too hot or it's too cold, but isn't there something that's just about right for most of these patients that have small thyroid cancers? And that's where we get to this paper. The idea that perhaps thermal ablation, and I'm going to just use thermal ablation, there's radiofrequency ablation, there's microwave ablation, there is laser ablation, there's nanopulse, which is not technically a thermal ablation technique, but all of these different techniques, could they be better? We know that they have similar efficacy to surgery. We know that, and that's not really the purpose of this paper, was not really to review the efficacy of radiofrequency ablation too much, because we know that that has been pretty well established in a fairly significant body of literature elsewhere. We know that there are fewer complications than surgery. You can see that on the right-hand side. And you know that you have a better quality, and we'll come back to that table in a minute. And we know that there's at least some data that suggests that patients have a better quality of life than they would have if they had upfront surgery. And so we also know that when you compare it to active surveillance, that it seems like there is less progression of that, 8 to 15% of patients who would go on to need surgery. Fewer patients progress if they have upfront thermal ablation. There may also be a decrease in the anxiety because patients feel that they're actively doing something more than just the active surveillance. And so maybe this could be an option to be that Goldilocks just about right that sits right in the middle. And that's what we're going to talk about today. So can we do more than doing less? Yes, we can do lobectomy, but could we do better than that? Well, maybe active surveillance, but is there something more than just doing that less that sits in the middle? So that's our background. Now let's talk a little bit about what this paper is and who was involved in it before we move on to what the actual recommendations are. This was a pretty significant recommendation. There were 41 authors, there were 10 surgeons, 26 radiologists, and 5 endocrinologists. As a surgeon, I would look at this right now, and I'm going to tell you that I'm going to come back to this at the end of my presentation today and talk about how this is actually a limitation of this paper, because we used a modified Delphi analysis, which I'm also going to show you in just a minute. But all of the experts that were included were very well established in this field of radiofrequency ablation or other thermal ablation. Each of them performed more than 50 ablations annually. They had significant publications. They were very well established in the field. They also, in this paper, did a small carve-out meta-analysis just reviewing the efficacy and the safety of these techniques. So this is the paper, how it was done. There was a modified Delphi, and the way that worked is, as you can see, strong recommendations. Each of us were given a proposed recommendation, and then we were supposed to score it on a score from 1 to 10. And you can see that strong recommendations were a priori decided to be anything with a score greater than 8. Sorry, it went up to 9. Between 8 and 9 was considered a strong recommendation, and it kind of went all the way down from there. You can see that the level of evidence, if you had a randomized controlled trial, if you had very strong other trials, you were considered a high level of evidence, and then lower levels of evidence were also included. We went through multiple rounds to see what the average score for each of these recommendations would come up being. So that's how the paper was done. So let's go through those recommendations right now, and we're going to go through each of these so that those of you who are kind of looking at this might have an idea about what's going on in this field of thermal ablation for small thyroid cancers. So the first recommendation in this paper is that you shouldn't start with cancer. And I think hopefully anybody that's considering whether or not they should adopt thermal ablation into their practice to help their patients should understand that if you're going to offer thermal ablation, you should be starting with benign nodules before you move on to cancer. You should be experienced. Cancer, obviously, the risks are higher, the stakes are higher, and so you need to be more experienced to make sure that you're taking good care of your patients. I'm going to skip some recommendations that seem like common sense. For example, number 2 is just talking about getting some preoperative labs. Number 3, ultrasound is the modality of choice for all of this. I know in my background, we have looked at using MRI in real time so that you can get some good thermal mapping. But considering all the available technologies, we know that a lot of radiologists will use things such as CT-guided either biopsies or ablations. We know that Considering all of the different things for the thyroid, the ultrasound remains the imaging modality of choice when you're doing thermal ablation. It goes without saying that you should have a diagnosis before treating a thyroid cancer. And so that can be done either through FNA or through core needle biopsy. And we also know that you should evaluate the voice before treatment. And that can be done either with an ultrasound when you're doing your preoperative evaluation, or that can be done with flexible laryngoscopy. So we know that those things are important before you get started. This is really the meat. This is, I told you before at the very beginning, the too long didn't read was recommendations 8 and 9. And the recommendation 8 is thermal ablation is recommended as one of the first line treatments for T1N0M0 Papillary Thyroid Carcinoma. And that's considered to be a moderate recommendation with high quality evidence. So what does that mean? That means most of us were pretty much in agreement, and there was significant evidence to suggest that patients who had cancers that were smaller than 1 centimeter without any metastases were good candidates to be considered for radiofrequency ablation or other thermal ablation techniques. So when you see a patient with a thyroid cancer that is smaller than 1 centimeter and doesn't have metastases, these patients need to be given the option of radiofrequency ablation or another thermal ablation treatment. They should know that this is something, in addition to active surveillance, in addition to a thyroid lobectomy, that they can be considering, and that there might be some advantages to it. Recommendation number 9, you can see the evidence is not quite as good for this one, but it says thermal ablation is recommended as an alternative treatment for patients with T1B-N0M0 papillary thyroid cancer who refuse active surveillance and surgery or are ineligible for surgery. So you see that changing. So the gold standard for these T1B tumors between 1 to 2 centimeters remains surgery. But there will be some patients who refuse surgery, and there will be some other patients who are ineligible for surgery. In that group of patients, you can consider thermal ablation according to this guideline. Now, it should be noted that this guideline was put out before the most recent American Thyroid Association guidelines for the management of thyroid nodules and thyroid cancers, which has recommended, in the past, we considered for active surveillance tumors between 1 to 2 centimeters. That guideline may be reduced in size down to the 1 to 1.5 centimeter mark. And so as you're looking at this guideline in the setting of evolving guidelines from other mainstream organizations, it's important to realize that there's not as much data for treating these larger tumors between 1 and 2 centimeters with radiofrequency ablation or other thermal ablations. And so that is something that you as a surgeon or as an endocrinologist discussing this with patients, you need to understand that there's not as much data to support these procedures in larger tumors. And especially, I would say, if you're a radiologist thinking about offering these techniques to patients, this is where I would be especially concerned if you don't have an extensive background in thyroid cancer and other thyroid pathology. It's critical to be aware of kind of what's going on here before you just tell a patient with a 1.7 centimeter tumor that they're eligible. Certainly, that would be a patient that you would need to understand the limitations. Now, I'm going to come back to why I think this was able to be approved as a recommendation later, but this is a pretty provocative recommendation, and it's recommendation number 10, and it says, for T1N0 tumors with minimal extrathyroidal extension, papillary thyroid cancer located in the isthmus, or multifocal papillary thyroid carcinoma with less than or equal to 3 nodules, thermal ablation is recommended as one of the alternative treatments for patients who refuse active surveillance and surgery or who are ineligible for surgery after careful evaluation. Now, I included the 2 references below that they built this recommendation on. And as an author, when I saw this, I frankly didn't really agree. I'm not convinced that multifocal cancer should be treated at this point. I don't think we have enough data. And so I put the picture on the right-hand side of your screen of somebody wearing fashion from Paris Fashion Week. And I think it's important to realize that there sometimes are things that some people around the world are doing or wearing that you wouldn't necessarily do or wear or recommend for your patients. And I think that this is probably a recommendation like that. We know that even multifocal papillary thyroid cancers have a really good prognosis. And so where do we start to expand the indications of these thermal ablation techniques versus where should we remember that some percentage of these multifocal tumors will actually be more aggressive. Where will the outcome start to devolve? Where will you start to see significant metastases? These are all questions that we don't have nearly as much data. And as you can see, there was a weak recommendation. And I think perhaps of the makeup of this panel, it was able to be included as a recommendation at all. But you can see that there's pretty low quality evidence to support this. Continuing with the guidelines and going back to something that really was able to achieve more of a consensus, even though there was not as much evidence, you can see that if you've already had a thyroid lobectomy and then you develop a new tumor on the other side, then that could be considered as something to be treated with thermal ablation. And so you can see the difference between all the different authors, that if you have multifocal tumors or a tumor in the isthmus, the authors weren't necessarily as excited about doing that as they were about offering it to patients who just have a single lobe left, but with just a single tumor. Continuing with these recommendations, you can see on number 14, the authors are cautious about proceeding with bilateral tumors. You can see that it's definitely necessary that when you are placing your local anesthetic, you should be very cautious about placing it close to the trachea, the esophagus, or especially next to the recurrent laryngeal nerve. The first two, because if you put numbing medication there, then the patient will not be able to provide you with the feedback that you are getting too close to a critical structure. And for the last one, if you use local anesthetic close to the recurrent laryngeal nerve, you will likely cause a temporary palsy, if not worse. And the reason is that some of that, we know that depending on the technology that you're using, some of that local anesthetic can also conduct the energy over to the nerve. And so you need to be very cautious when you're placing your local anesthetic. We know that hydrodissection is required, and that's, again, why you need to be an experienced ablative proceduralist before you move forward with these more advanced tumors. And we also know that there's different techniques that you can use. With very small tumors, more of a fixed placement and just activating that electrode at the end within the tumor is appropriate. And with larger tumors, you should be considering the moving shot technique that we're all familiar with. Intraoperative complications certainly can happen. And that's why these guidelines suggest that if you have voice changes, you shouldn't do the other side. If you also need to be thoughtful as you're planning your patients, that if you need to be treating these patients for the entire volume of the carcinoma, plus a margin of about 2 millimeters all the way around that tumor. And so if you have a tumor that abuts your danger triangle or your nerve or your trachea, you need to be thinking, how am I going to be able to ablate an extra 2 millimeters circumferentially around this tumor? If you get into bleeding, recommendation number 25 talks about how you can use ablation hemostasis to help, and that you should also be intermittently checking the vocal cords with your ultrasound, where you can examine the false vocal cords pretty easily. And that's something that you can do to make it safer. Now, what are the complications? This is part of that meta-analysis that was built into the paper. As you look at these complications, you can understand why it's appealing relative to surgery. Even the most likely complication is transient hoarseness, and that happens in approximately 2% of patients. Permanent hoarseness is very unlikely. Hypocalcemia, which is certainly a risk if you're doing a total thyroidectomy, or hypoparathyroidism, those are not risks if you are doing this procedure. And so when you consider the way that patients are currently being treated for papillary thyroid carcinoma, it's apparent that thermal ablations might be safer and probably are safer than those other techniques, especially in the hands of experienced proceduralists. This is just a demonstration from the paper looking at the fixed versus the moving shot technique. On the left-hand side, you can see if you have a small tumor, you can just place the electrode or your antenna right in the middle of the tumor, treat that tumor, and then you'll be done with the case. Whereas if you have a larger tumor on the right-hand side, you need to be actively moving that electrode or antenna to make sure that you've treated the entire tumor. Additional recommendations, I thought noteworthy to walk away with a recommendation about follow-up. You should be having follow-up at 1, 3, 6, 12. For the first year, follow up pretty regular, and then every 6 months out to the 3-year mark. And then after that, an annual ultrasound follow-up. Who does that follow-up? We, as proceduralists who are doing it, are in the best position to understand what we see and that what it relates to with regards to within the tumor that we ablated previously. And so certainly we need to be involved in this as that's going forward, certainly especially for the earlier sonographic follow-up and follow-up visits. You also need to be evaluating the lateral neck and the central neck lymph nodes as well, not just the tumor itself. If disease progresses, interestingly, a CAT scan of the chest is recommended to make sure that there's no distant metastases. So what are my thoughts about the limitations of this study? And you can see again the Paris Fashion Week on the side there. One of the strengths of this paper is that it has a lot of international physician recommendation. And it's also a strength that there's many radiologists. I think one interesting thing for those of you who haven't been over to China to observe this directly, in China where this paper was kind of spearheaded, there's actually an entire different discipline or specialty different than what we have in the United States and in the West. And that is a specialty of ultrasonographers who are ablative intrasonographers. And so whereas in the United States, you have interventional radiology that kind of might do a little bit of everything, in China, there's actually just ultrasound physicians who just do ablations and ultrasounds. And many of those people were people that were made up this panel. If you recall, there was the majority, 26 of the authors on this paper were radiologists, and the majority of them came from China. And because of that, this has a pretty strong skew in favor of doing perhaps a little bit more than we might do in the Western world. It's a concern that I think a lot of us share. When you go to a physician who only offers one technique, then that technique is likely to expand to be the best option for more and more patients. And so I think that's a little bit of what we might be seeing here. Should we be using this technology to treat multifocal tumors? I'm not exactly sure. In my practice, that's not something that I usually consider to be the ideal. Certainly, if you've got up to three, I'm starting to slow down, and it becomes a very extensive patient conversation. Certainly, right now in the United States, this guideline does not represent the standard of care, but it may be more of something that is aspirational for those of us who are doing thermal ablation, and for those of us who have patients who are looking for thyroid preserving opportunities to consider. And so I don't know that you and I are going to be wearing the red flower dress on the right-hand side. It looks fantastic, but I'm not sure it's going to go with my eyes. But maybe for certain people, it would be the right thing to use in the right scenario, in the right setting. So this kind of my synopsis of this thing is, if for some reason in North America you were to biopsy a tumor that is smaller than 1 centimeter and you find out that it's a papillary thyroid carcinoma, I think you should definitely be offering thermal ablation as a first-line option. Joint with active surveillance, joint with lobectomy, you should be talking about thermal ablation. I'm not as excited about it for tumors between 1 and 2 centimeters. I think we do know that some of these tumors can be more aggressive. There certainly are some patients who are highly motivated, and in the right setting with the right resources available, that may be appropriate from time to time, but certainly only if you have extensive experience with benign tumors, and you should plan to proceed very cautiously as you're doing this. So I just very briefly to share my experience, this is work that I did when I was at Johns Hopkins, and this has been presented before, but you can see our first 15 patients, this is what our results were. You can see that we had a number of patients were able to achieve a complete disappearance sonographically. And most of our patients were able to achieve, our mean volume reduction rate was 98%. And so it's pretty effective at getting most patients to decrease the size of their thyroid cancer. But you can also see, if you pay attention, that we had a couple of patients who had temporary palsies that were not insignificant, with one of those palsies lasting almost a full year. You can also see that we did have a patient who, after treatment, went on to develop cervical nodal metastasis. And so I think these are important things as you're talking to your patients, to really find out what your patient is most interested in. There's pretty good data that said that these techniques can be safe, especially with regards to long-term complications, and especially when compared to active surveillance. And so if you have a patient who's interested in active surveillance, this is very much a good option, because it very possibly could reduce anxiety. If you have patients who are on the fence, is also a good technique, something that could be advantageous. But if you have patients who really are looking for something more definitive, then probably thermal ablations, we probably need more data before we can advocate for this being a long-term solution for patients who are very motivated to have something more definitive than thermal ablation. And I will stop sharing my screen. And thank you very much for the opportunity to present.
Thank you, Dr. Russell. That was a very, very interesting presentation. We're gonna jump right ahead with Dr. Sinclair's discussion, and we'll come back at the end for a little bit of a discussion.
Thank you so much. I always love listening to Dr. Russell speak because he has such wonderful anecdotes that he always manages to add in there. And I particularly love the red dress. I have not worn a red dress in many years, but it has actually stimulated my interest in potentially wearing a red dress, although not exactly of that sort necessarily. So I have the honour today of being the discussant for this fairly landmark article that was, as Dr. Russell mentioned, a number of authors, multiple specialties, and really tried to sort of, set some standards for ablation of papillary microcancers. And this is an area that there's, as we all know, there's been a rapid expansion in the use of ablation in benign disease worldwide, but particularly in North America, United Kingdom, now in Australia, really over the past 5 to 10 years. And this follows on from these techniques being available in parts of Asia and Europe for decades. And so, there's, every single month now, there's a plethora of data that's being released in multi-specialty journals about ablation for benign disease, but now also about ablation for malignant disease. And it's very important to sort of mention that although we have so much data on benign disease, we still actually have a lot to learn about the nuances of patient selection, of which nodules respond well, of what procedural specifics we can do to optimize outcomes. And that's with benign disease. So you can imagine, given benign disease ablations have been going for decades and there's still a lot we don't know. There's definitely a lot we don't know about ablation for both microcancers, cancer recurrences, and cervical lymph node metastases. So, I think this consensus statement overall represents a shift towards greater acceptance of thermal ablation as an alternative to surgery for appropriately selected T1A patients. And Dr. Russell mentioned T1B patients, and I'll mention that again because I think we all have some reservations when it comes to larger cancers and the ability of ablation to cure these patients. And so it may be that statements like this and future statements, influence guidance bodies to incorporate more detailed options into their algorithm for malignant disease. So, sorry, I'm just trying to get my screen. I have no disclosures related to this presentation. I think that, as I mentioned, the breadth of the author panel is impressive, but there definitely was a predominance of radiologists in the author panel, and perhaps some of the recommendations, particularly the slightly more aggressive recommendations that Dr. Russell maybe has some hesitation about endorsing, probably relates to the demographics of the author panel a little bit, but overall a really great attempt to sort of standardise pre, peri and post-operative care and follow-up for patients with this type of disease. So I've just got onto ChatGPT. I was encouraged to get onto it by some colleagues at the American Thyroid Association. I'd never touched it before, and I thought, well, what better way to see what it can do than just to see what articles have been released in the last few months, and ChatGPT it and then compare it to Medline. And actually it did fairly well. It missed out some landmark ones, but I've just put this slide up really just to show the rapid explosion in the number of trials and clinical reports on the use of ablation in malignant thyroid conditions that has occurred in the last few years. These reports are all from 2025, really in the last 6 months. And this is just a smattering of what is available. And what we see here is that the reports range from the use of ablation in microcancers through to the use in recurrences, through to cervical lymph node metastases. So the indications, or I hesitate to say indications, but the uses of ablation and the way ablation is being used in certain parts of the world is expanding very rapidly. Now, that doesn't mean, as Dr. Russell correctly said, it doesn't mean that we necessarily should be doing it. And I don't think we have the long-term data to support the use of it in many of these indications, but it is interesting to see just how rapidly things are expanding in this field. So this was a table I made actually quite a few years ago now, and it just shows some of the early studies that looked at using ablation in papillary microcancer. And you can see that all of these studies are out of Asia. And the interesting thing with the Asian studies is that they will biopsy tumors that are under a centimetre in size. And actually over half of the papillary microcancer cases I've done here in Australia have come from patients who have had health screens in China and have had ultrasounds done, small thyroid nodules of the 4 to 6 millimetre size identified, and then had biopsies of those nodules, and they've been diagnosed with papillary microcancer. And so the generalizability of these studies to populations where we don't biopsy nodules under a centimetre, and actually therefore these nodules may fall more into the early T1B category when we actually get to ablate them, it's a little difficult to generalize some of this data across, and we have to keep that in mind when we counsel our patients and start telling them, well, ablation dramatically reduces your risk of recurrence in terms of tumor growth or metastasis to cervical lymph nodes, because sometimes I feel that generalizing this data, particularly that out of Asia, is maybe not accurate to the patient populations in North America and definitely here in Australia. So there's been a number of meta-analyses and systematic reviews done now over the years. These were a couple from a few years ago now. And, they kind of support those early trials showing that, with ablation, you can reduce the kind of 8 to 10% chance of recurrence, be it by tumor growth or cervical metastases, that you would get if you just did active surveillance of these tumors. But I think all meta-analyses and systematic reviews so far have had to acknowledge that the data is extremely heterogeneous. And many of the available studies are observational and non-randomized. There's relatively short to moderate follow-up in the order of like 1 to 5 years in most studies. More recently, there's been a couple of longer-term studies released, but really not enough data for very long-term follow-up in large cohorts to enable us to make generalizations to how this treatment will, or what outcomes this treatment will provide as we, head into decades after treatment. There's also sometimes patient selection bias in that these studies come from centres, high volume centres, very experienced proceduralists, which perhaps don't accurately reflect the proceduralists who may be attempting to do microcancers in other countries. And also there's a lot of technical variability between the studies, different ablation modalities used, different ablation parameters, variations in operator skill, variations in energy, etc. So I think these considerations all make drawing conclusions about the long-term usefulness of ablation for any individual patient with thyroid malignancy fairly difficult at the current time. So where are we in 2025? And I think, as I've alluded to, many unknown factors remain. And I must say, when I first read this consensus statement, I kind of raised my eyebrows when it came to the T1B and multifocal recommendation. And I was very pleased to hear that Dr. Russell and I are on the same page, as I thought we probably would be. But it was nice to hear him mention that this was something that he also felt a little uncomfortable about, because the fact is we don't have data, good data, on T1B and multifocal tumours. There are some preliminary studies that have come out, a couple out of China looking at multifocal disease, suggesting that these respond as well as unifocal disease. But again, these studies are heterogeneous. They lack a number of variables. And so we can't draw conclusions about that data at the moment. I think when we move into the T1B realm, we need to start thinking about the difference between ablation for benign disease versus ablation for malignant disease. So when we ablate benign disease, we're not concerned about there being viable cells left. In fact, we expect there to be some viable cells left, particularly with the larger volume nodules. And what we're relying on is getting rid of that blood flow and, that inflammatory response to induce scar tissue and bring that nodule down in volume. But having some viable cells left, yes, maybe it can regrow, but that's, will take quite a while in many nodules, and it's not such a big deal as long as patients are counselled about it beforehand. But when we start talking about malignant disease, having viable cells left, well, I think that creates issues, and definitely in terms of risk of cervical metastases, potentially increases it if there are viable cells remaining, although we don't have data on this to show it. But just from a theoretical, hypothetical viewpoint, it would make sense to me that if we're not knocking off every cell, then we're not really curing the disease. And that's my concern as we start to get to the use of ablation in larger volume cancers. It's that ability to kill every viable cell, which I'm not sure that we can as the size of the tumor increases. So I think that's something that time will tell, and it's something we need to think about. But definitely the larger a tumor gets, the more concerned I get about using ablation to treat it if it's malignant. Other things that we really don't know, optimal diagnostic pre-ablation testing, in this consensus and others, there's a mention of core versus fine needle biopsy. Should we be doing core biopsies maybe on all of these, and molecular testing, to really assess core biopsy for tall cell variants, for, or other, more aggressive variants, molecular testing to, look at the gene variations? We don't know. And, and it's similar, I guess, a little bit with active surveillance, but with ablation, we're also changing the appearance of the tumor. It's in some ways, if it doesn't disappear completely, it can be harder to follow. And so all of these things have to come into the decision making when we're trying to decide what diagnostic things do we need to make sure this patient is a good candidate for ablation. And then there's other things like, the optimal treatment factors, energy delivery, optimal treatment margin. We usually treat these with a buffer zone of about 2 millimeters. And, we will ablate anteriorly into the straps if necessarily, but posteriorly located tumors, tumors immediately proximate to the trachea, if we can't get a good margin on it, they really aren't great candidates for ablation at the current time. But then the question arises surgically, sometimes these tumors are right on the margin. We may not take a big margin of tissue. Is a margin necessary? We don't know. Predictors of failure and progression, is it similar to active surveillance? Is it different? Do we alter the tumor characteristics by heating them up and burning the cells? Follow-up duration. We, in this consensus, it mentioned 1, 3, 6, and 12 months. That's maybe seems a little aggressive to me, but I think if you're starting out with ablation, following people up more frequently is good, but definitely 6 and 12 monthly for a number of years would seem sensible, as with active surveillance protocols. Who should do it? I agree with Dr. Russell. I think the proceduralist, we have a duty of care to our patients to follow them up. But obviously that doesn't happen everywhere. And particularly with patients coming in from interstate and from other countries, it starts to get very tricky. And so all of these things are considerations that are particularly pertinent in my mind for malignant disease. And I think it's nice to see the American Thyroid Association management guidelines did include a note in recommendation 11B on ultrasound-guided ablation for T1A tumours. But, again, low certainty evidence. And so it's now reaching guideline stage, but we still don't have a lot to back it up. So what are the challenges for widespread uptake of ablation for PTMC? I think one of the things is the lack of long-term data, and that will come with time, and also the limited amount of data outside of Asia, where a lot of these tumours, the T1A tumours that are treated, are much smaller than perhaps we see in North America or here in Australia. Aggressive variants, is it suitable for aggressive variants? Actually, we don't really know. So that's another thing, but definitely is a challenge to widespread uptake, particularly where we don't have molecular testing easily available, and training variability, regulatory and insurance barriers. So future directions, there is a lot happening in the technology of ablation, and, integration with AI and imaging, improved ablation devices. All of this is coming. Nanopulse is a promising field, perhaps particularly for nodules that are in danger zones or critical areas, with its sort of improved or apparently improved safety profile. So I think watch this space. But we don't have any long-term data on that technology either as yet. So we don't know how it will perform when used to treat malignant disease. But again, it's something to watch. So there's a lot happening, and a lot will change, fairly rapidly, I think, over the next 5 years. But we're sort of in the infancy here. So I think in summary, there's opportunity to conduct very high quality prospective trials with long-term follow-up, comparing ablation to surgery to active surveillance in T1A lesions, definitely. And obviously that's going to be extended out to T1B lesions in a number of centres. Setting up registries to help collect sort of real-world outcomes in multi-centre format will be useful. Further refinement of imaging and monitoring techniques will hopefully help predict which patients will have complete tumour disappearance versus recurrence versus residual disease, and allow us to sort of minimise morbidity. And I think, as practitioners, whenever we see recommendations and guidelines, we should adopt them thoughtfully. But the main thing is to ensure that we're patient-centred, and particularly for malignant disease, that there is shared decision-making between patients and practitioners, and really very careful adherence to technical and safety standards to optimise outcomes. So I'm going to finish there and hand back to the moderators of this session. Thank you.
Thank you, Dr. Sinclair. Thank you, John. I want to thank you both for your presentations and for your work in the field, both your position and voice through the different societies who have pushed the field forward. And not only that, your care for the safety of our patients and advising not to wear the red dress just from the get-go, I think is very valued. I'm going to start us off with a couple of questions from the audience. I think one of the questions everybody has at one point of their career is if we shouldn't biopsy sub-centimeter thyroid nodules, why are we having patients? Why do we have microcarcinomas? I think besides the known differences in health policies between different international societies and wherever you might practice, do you find any other reason why we're finding so many patients that are looking for thyroablative techniques for sub-centimeter thyroid nodules?
Dr. Sinclair, I don't know how it is for you, but I will say that just over the arc of my career, this has become much less prevalent, which is good to see that even in the community, people are realizing we don't need to biopsy these small tumors. The exception would be certainly there are tumors that are in tight locations where somebody's worried about it, or you have an exceedingly anxious patient, and we will see occasional biopsies. But these are becoming more and more rare, at least here where I practice.
I agree with that, John. I think it is becoming rarer. And as I mentioned, probably about 50% of the people I see with T1A lesions have come from other countries where they've been on holiday, got health screening, had a biopsy, and they come with a biopsy in a different language that then has to be translated to, so that I can understand it. And, usually with papillary microcancer, and they're the ones that I have had that are under a centimetre in size, because yes, that's, or as John mentioned, the anxious patient, because that's the other. I've had a couple of patients who have just, really, really, really needed to know, and they've had health anxiety, and it's been kinder to do that diagnostic screen to everyone involved than not. Yeah.
Thank you. I'm gonna use one of the questions that was from the audience, but Dr. Sinclair, you mentioned that there's differences between how we ablate benign versus cancer, and with that regard, do you? And I know this is not the main focus of the presentation, but do you prefer any ablative technology over another, being a benign or cancerous thyroid nodule?
So my expertise is really with radio frequency, and I think radio frequency with the smaller probes, the 2.5 or 5 millimeter tip, gives you very nice control for these smaller lesions. And I think microwave has a role for larger volume disease. I haven't used it at all myself, but I would consider it for larger volume disease. But I think for that fine control, I definitely favour radiofrequency. And to your point, we do treat them a bit differently. We do try and take a margin of tissue, which with benign disease, we actually do the opposite. We try not to go outside of the capsule, not to weaken the capsule, and even to the extent in critical areas of maybe leaving a tiny bit of tissue if we've got concerns about injury to viscera or nerves. And so it's quite a different technique from ablation of benign disease. And I agree with the recommendations that were made in this consensus about this is ablation of malignancy is for experienced ablation proceduralists, not for the beginner, because it is, even though the ablation is very quick, it's actually a very nice ablation to do. It is tricky to get that electrode into a small lesion and then to move it around. And we use not a moving shot, we sort of use a multi-shot technique, because you can't really use moving shot because these things are often so small. So, yeah.
John, in regards to the complications, you shared with us a table, and I think, and correct me if I'm wrong, that clusters both microwave and RF as one and same cluster. Is that correct? So complications, you wouldn't find them any different if you used one versus the other technique?
No, I think Dr. Sinclair would agree that most of the studies, especially in the very beginning stages, have shown that microwave ablation does have a higher complication rate. And over time and with experience, that does seem to be fairly similar to radiofrequency ablation. But especially for these small tumors, when we're talking about cancers, unless you are a very experienced operator, maybe only using microwave ablation, most people will turn to radiofrequency ablation, certainly in the Western world at least.
Correct. Now, speaking about ultrasound features and follow-up of a patient, I had the chance to glance over the table that you presented when you were at Hopkins, and you showed, well, the size of those nodules. You showed also some features, what happened with those patients. And I found it interesting that you had the TIRADS change. Could you speak a little bit to that? I know TIRADS and the current ultrasound feature analyses do not account for ablated nodules, but teach us a little bit, what should we be worried about for the less savvy as myself? Tell us.
So I will answer this briefly, but then I'll turn to Dr. Sinclair, because Dr. Sinclair has really spearheaded a group, and she was kind enough to invite me to be involved in this. But we know that changes happen after ablation, and we have always assumed that those ablated nodules will become more suspicious after we've ablated them. It's interesting with the cancers, in our experience, they almost sometimes will look less suspicious because you'll have cystic areas. But again, Dr. Sinclair is leading this group that I am part of. But Dr. Sinclair, maybe you should finish that question.
Oh no, I wholeheartedly agree with you, John. I think that the things that we're looking for in benign nodules post-ablation and malignant nodules post-ablation are a little different, in that with the malignant, we are actually looking for disappearance of the nodule, which should be achievable with these smaller nodules. Whereas with benign nodules, we're looking for certain appearance changes and characteristics, and we're not actually expecting those larger volume benign nodules to disappear. In fact, they very rarely do. You'll be left with a ball of scar tissue. Whereas if you're left with a ball of scar tissue and it's been a malignant nodule, then that's pretty much an indication after a year to rebiopsy and see if there's still malignant cells there. So it's a bit of a different playing field when we're talking malignancy from benign and follow-up in terms of what we're looking for. And the group that John mentioned, we're mainly focusing on benign for this particular statement, because that's what's being done in a more widespread way. But I would say with malignant, we're really wanting disappearance. And if there's not disappearance, we should be considering rebiopsy, after a year, in my mind.
Now, speaking about biopsies, we usually use fine needle, but core is also accepted. How do we read a biopsy after an ablation? Is it the same method that we use, or are we just dichotomizing like malignant versus anything else? Because it could be expected that at least a tibia will come out of a healing of the normal thyroid tissue.
So we've done a study about this, and I know a couple of other groups have as well. The beauty of it is if you've got a benign nodule, that you've treated with radiofrequency ablation, you should expect that follow-up biopsy will also be benign. We all were worried that maybe it was going to show atypical cells because of inflammation. That does not seem to be the case. With these malignant tumors, you should expect to see essentially just an acellular scar, like Dr. Sinclair just talked about. And if you're seeing atypical cells, that's probably cause for alarm and for a pretty frank discussion with the patient about what the next steps of care should be, whether that's a retreatment or a surgical intervention.
Dr. Sinclair, any final words, questions?
I think I completely agree. I think the indications for rebiopsying these microcancers or these malignant lesions, are still being defined, but given that we are looking for complete disappearance or just a fine, hypoechoic scar, anything outside of that, we have to treat cautiously, and we should not be seeing atypical cells in those biopsy specimens. So if we are, then that, as Dr. Russell said, that's cause for concern and a frank conversation with the patient.
In regards to molecular testing, because that was brought up earlier, is there any mutation that would drive you not to do ablation? A couple of weeks back, we had Teresa Ramona here present on the follow-up of active surveillance in patients with BRAF that were BRAF mutated. And apparently, the prevalence of BRAF is high in thyroid nodules, and it does not change the as a prognosis factor how the nodule will behave. It does not change a whole bunch unless you have additional mutations as a second hit. Is that read any different in the realm of ablative techniques?
I mean, there's been a couple of studies, again, out of Asia looking at molecular mutations, BRAF being one of them, and not showing any difference in outcomes for ablation of BRAF positive microcancers versus BRAF negative. BRAF itself doesn't concern me. I think some of the combined, the TERT BRAF mutations, combined mutations, I would have reservations about that. The issue is here, the Bethesda 6 nodules we don't have access to molecular testing easily. And it's the indeterminate nodules I won't ablate without molecular testing. Actually, the Bethesda 6 ones, I don't molecular test. And maybe I should be insisting on it, but I don't molecular test. So, as long as they don't have cervical node metastases, it's in an appropriate location and it's appropriately sized, I treat those nodules and then follow the patients up fairly diligently. But, this is a good question. Should we be molecularly testing all malignant nodules so that we do know what the mutational status is? I don't think we have the answer to that yet, and I don't think we're quite at the point of letting mutational status guide our treatment decisions completely. But it may well get to that point within foreseeable future.
I'm just going to piggyback on that, just how exciting this field is right now. I remember sitting in my cubicle at Johns Hopkins in 2015, staring at these fantastic papers that have been written for more than 100 years, and just thinking, there's nothing else to research in thyroid. How am I going to make an academic career out of this field? And here we are 10 years later, just looking at it saying, we have no idea. And it's a really exciting thing to be in the field that is changing so quickly and making care better for our patients. It's fantastic.
I couldn't echo that more. I hope I could keep you here for another hour, but it's almost breakfast on a Saturday in Australia. So I want to thank you both for being here. Thank you for your time, as I said before, for your work in the field. And I want to invite everyone to come back next week for one more presentation of the TIRO by MDs. We're going to have Dr. Ito and Dr. Louise Davies speak about prognostic factors in PTC and FTC. So we're looking forward to that. Thanks, everyone. Also, I'd like to invite everyone to tune into the Voices of Wisdom podcast by Dr. Dana Hartle and the TIRO group with excellent pearls of wisdom in thyroid nodule and thyroid cancer care. So thanks, everyone, for being here. Have a happy and safe weekend.